Hi, this is Giuseppe Argenziano from Naples, Italy, and today I would like to share with you a recent article that we published together with our pathologists. And the title of this article is Second Diagnostic Opinion by Experienced Dermatopathologist in the Setting of a Referral Regional Melanoma Unit Significantly Improves the Clinical Management of Patients with Cutaneous Melanoma. In a word, what we found in this patient, that based on a sample of about 120 lesions, the second opinion, so the review of the histopathologic slides of lesions removed in the territory and reviewed by our pathologists, this review was able to change the management, the treatment management of our patients in 27% of cases. So it's about one case every 4. Can you imagine? It's a lot. And in which way, let's say, the change in management was happening based on the fact that first, many borderline indeterminate lesions, at least classified as such in the territory, in the hands of the first pathologist, were categorized as nevus or melanoma by our pathologist. The second point, as you can see here, is that in general, in the periphery, so the first pathologist was on the average diagnosing many more melanomas in situ than our pathologist. On the opposite, our pathologist was diagnosing more benign nevi than in the peripheral pathology. Okay, so this is this kind of changing scenario after the second opinion was basically affecting the management of our patients. Okay, let me give you an example here. This is a 52-year-old woman. The lesion is located on the back. Dermoscopy showing an atypical lesion with a typical network. The first histologic examination was diagnosing this lesion as a sampus. You know what is sampus? Sampus is an acronym meaning superficial atypical melanocytic proliferation of uncertain significance. So a borderline lesion. Okay, but by reviewing this case in our pathology, we were able to categorize this lesion as definitely an in situ melanoma, and therefore we were managing the lesion accordingly. Okay, in this second case, the lesion is, as you can see here, dermoscopically, is a pretty great looking spitzoid lesion, you know, with this starburst appearance of these streaks at the periphery, regularly distributed at the periphery. But we know very well that at least a small proportion of melanomas can exhibit really exactly the same morphologic features as we see in spitz nevi. And the more is the age of the patient, the more is the probability that this spitzoid-looking lesion is not a spitz, but a melanoma. Okay? And in this case, this is a 61-year-old woman, the lesion located on the chest. Look at the dermoscopy, look at the histology. This lesion was, at the first glance, diagnosed as a spitz nevus, but in our pathology, it was diagnosed as a melanoma with spitzoid features, and therefore the patient was managed accordingly. Here you can see basically all the cases in which a management change was happening from the first to the second diagnosis. So 27% of cases we changed our management, and just look at the last piece of cake, bottom right, change in ray biopsy plus sentinel node biopsy. So basically, for the great majority of cases, 92% of cases, of course, we confirmed the first diagnosis, and therefore we performed the re-excision plus the sentinel node biopsy. But in 2 cases, we didn't. So the second opinion was changing completely the management of these 2 patients. So instead of doing all this surgical procedure, we didn't. But even more, in 7 cases, we changed on the opposite. So we decided to perform sentinel node biopsy plus re-excision instead after the first pathologic diagnosis. It was not indicated. So this is what I wanted to share with you, and thank you for your attention.